Well, we're already 10 minutes behind here. Actually, more than that. Usually, people are kind of coming in. I give a little bit of extra, talk on the patellofemoral joint, on the anatomy, which is a little bit. We've done some work to correct that. The typical anatomy of the prepatellar bursa in the textbooks shows a single prepatellar bursa. And the Belgians talk about a new anatomic finding, the anterolateral ligament, but it's not really a new finding. The Segond already kind of showed it before. But we found that a few years ago that the prepatellar bursal system, in fact, is a system of three intercalated bursae, with the deepest one being a subaponeurotic bursa, not a subtendinous bursa like the textbooks say can exist. And so we've suggested this name for that deepest bursa, the prepatellar subaponeurotic bursa. And here you see this in a patellar specimen. And so it's not a single bursa as represented in Gray's anatomy or Grant's atlas. And if you notice, Grant's atlas has this very famous Rembrandt painting. You're probably all familiar with this. What's interesting about the Rembrandt painting for the upper extremity people in this audience, if you look carefully at the anatomy here, you'll see that this doesn't look like the volar tendons it's supposed to be in the left upper extremity. These are in fact, the actual dissection was done as the dorsal tendons of the right hand, right upper extremity, drawn as if they were the volar tendons of the left. And Rembrandt put it here for compositional purposes. So notice here, this is kind of a foreshortened arm. He drew this in later. So this is incorrect anatomy. And so all these guys are studying studiously incorrect anatomy. So this is appropriate because this is incorrect too. Now about a year after we published our work in the Journal of Bone and Joint Surgery, the Lancet published an article by three German anatomists. And the German anatomists, gross anatomists, are the best in the world, basically, and they did most of their work in the 19th century and in gross anatomy. But they said that we basically got it correct for the first time and basically said we had a new discovery. So anyway, that's just a little anatomy cartoon, if you will. So now I'm going to get into the workshop topic, which is patellofemoral pain. Now, I don't know how many of you here are, how many here are rheumatologists? Any rheumatologists? Or are we all orthopedists here in this group? Well, okay. Well, I assume we're all interested in the knee to some degree or other. In the orthopedic realm, patellofemoral pain is known as a classic enigma. And even today, there's a lot of controversy on this, and yet it's one of the most common conditions of the knee. It's amazing that we're still having debates about this. Now, I approach this and other topics looking for principles rather than methods. A lot of my orthopedic confreres like to look for methods. How do I, what surgery do I do? But principles are more important. Now, anterior knee pain, which is another word for patellofemoral pain, has resisted all attempts at explanations through the standard structural and biomechanical paradigm. And why is the treatment here so difficult? It's because primarily we're dealing with a subjective report. Pain is a function of central nervous system events, and we cannot tack that down. We don't have a PET scan that shows perception of pain in the central nervous system. And so we're trying to then attach structural characteristics to the perception of pain, which we're not able to do at the present level of technology. So the symptomatic patellofemoral joint has two main problems: instability and pain. And those of us in the orthopedic community know in the past, probably 10 to 6 years, in the major orthopedic meetings, when you have instructional courses, it's about patellofemoral instability and arthritis, things you can talk about and can maybe deal with surgery, but nobody talks about patellofemoral pain because it's a more difficult topic, although I'm going to try to submit an instructional course to ISACOS meeting next year in Lyon. Now, John Insall, I don't know if you know his name, but those of us in orthopedics know his name. He dealt with patellofemoral pain for many years before he got into total knee replacement at special surgery and then on to another hospital. But this is his quote before he died, and he said, curiously, despite the widespread use of MRI and arthroscopy, the genesis of patellofemoral pain still remains an orthopedic enigma. So here's John Insall, who loved studying patellofemoral pain all his life, said, gee, we still don't understand it despite MRI and arthroscopy. Now, this reflects directly the inadequacy of the current biomechanical and structural paradigm, because that's what those techniques give you. And it misses the underlying homeostasis characteristics. Now, in orthopedics, most of us get just structural imaging. Most orthopedic surgeons, if you have a knee problem, they go right to the MRI and forget all this other stuff, maybe an x-ray. Very few do think about metabolic imaging, bone scan or PET CT. So almost never do orthopedic surgeons consider the metabolic column here. Particularly, almost always, just an MRI. But the MRI is limited in the kind of data it can give you. Now, the problem, in my opinion, as I talked about yesterday with early onset arthritis, is a belief in a pure biomechanical and structural paradigm of the knee. These are the kind of things you can see. You can see if it's tilted. You can see if it's got chondromalacia. You can see if you've got some effusion. But that doesn't tell you what's the full picture. Now, the entire orthopedic surgical profession has been based on a structural and biomechanical paradigm. It helps to understand this, and this is conceptually limiting, in my view. Look at our lexicon. You have the fractured bone, we stabilize it. Herniated disc, remove the herniation. Ruptured ACL, reconstruct it, or the knee won't work. Of course, that's not true. There are a lot of people with an ACL injured knee without surgery who do well through functional muscle sequencing. Ruptured tendon, repair it. Dislocation, reduce it. Chondromalacia, fix the cartilage somehow. Well, as I showed you yesterday, and I'll show you today, I've got grade 3 chondromalacia for 14 years without having it fixed, and I'm doing perfectly fine. You don't need to fix chondromalacia. And in fact, chondromalacia doesn't really cause pain, as I'm going to show you. So the assumption has been address the observable structural and biomechanical characteristics, do a chondroplasty, do a lateral release, do a proximal and distal realignment. The pre-injury knee function has been restored, therefore, and it's okay to return to sport, and DJD will be prevented. This is the underlying concept, but it's a limited tunnel view of what's extant in a living joint, because a lot more is going on under the surface than what you can see structurally. Now, think about patellofemoral pain, and what makes it such a horrible problem in orthopedic surgery is that the worst cases are iatrogenic. The worst cases are iatrogenic in my cases that I've seen in my practice. These are cases right out of my practice. I didn't do any surgery on these patients when I first saw them. 5 operations, 7 operations, 9 operations. Each one of these patients started before their first surgery with mild intermittent anterior knee pain, mild intermittent anterior knee pain. And then each one had surgery, and they got worse after each surgery. And each surgeon thought they could correct it, or you overcorrect it, or they had medial patellar instability, or some horrible problem came out from it, or finally complex regional pain syndrome, or something really bad happened. So iatrogenic injury is where the real problem of patellofemoral pain is. So how do we best achieve restoration of joint function? Do we do this by structural or biomechanical characteristics? To me, again, this is conceptually limited. Or by restoration of tissue homeostasis, this, as I talked about yesterday, an emerging orthopedic paradigm. And in fact, it was discovered and developed to understand in response to this enigma of patellofemoral pain. So what is the pathophysiology of patellofemoral pain? We can't get at the heart of any condition without understanding the pathophysiology, it seems to me. So what are the 3 main things that are currently talked about in the genesis of patellofemoral pain? Chondromalacia, malalignment, and tissue homeostasis. So let's talk about Chondromalacia patella. Now, this is from this morning. Go to the internet search, July 29th. That is today. Go on the internet. Mayo Clinic. Now, the Mayo Clinic has this, supposedly the best concept of pathology or medical problems in the world. This is right from their thing today. Damage to this is the definition of Chondromalacia patella, according to them. Damage to the cartilage underneath your kneecap. A more accurate term for Chondromalacia patella is patellofemoral pain syndrome. They are equating Chondromalacia patella with patellofemoral pain syndrome. Now, this is nuts. because it says when you have chondromalacia, it means you've got patellofemoral pain. It says it equates it. This is terribly wrong, and for the Mayo Clinic to do this is really shocking. And when I have time to publish some more of my ideas, I'm going to dial up Diane Dahlman and say, oh, Diane, come on, get this corrected. It's really stupid. And if you go to Wikipedia, and a lot of people go to Wikipedia, very first thing to understand what's going on in the world, here's Wikipedia, again, this very morning, 8 hours ago. Inflammation of the underside of the patella, softening of the cartilage, more accurately referred to as patellofemoral pain syndrome. The cartilage is no longer smooth, and therefore use and movement is painful. What? With no explanation of how it's painful or what causes the pain. This, again, it's total BS. You know what I mean by BS, people from outside America? Bullshit. It's crap. It's just total and utter nonsense. Inflammation, where's the inflammation? Of the underside, this isn't inflamed. Okay. So, again, this is the stuff that's out there. Now, those of you here yesterday know that I've had my knees arthroscoped without anesthesia 14 years ago to come up with a neurosensory map of the knee. And here's that map. One of the most important things we found from that study was that I had chondromalacia patella, grade 3. Here's a probe up in that. That's my right patella with no anesthesia. I didn't feel a thing. It was totally and utterly asymptomatic. And I remain before you today without symptoms whatsoever. 14 years, and I'm not a small person. I've been tromping around 2 million load cycles a year. I hike the headlands in Marin County. I've been to Switzerland many times and hiked. I've been to the Matterhorn. I've been to the Zumgipfel, in the Matterhorn when I was 27. Maybe it caused some of this, but I'm asymptomatic. So, no pain, standard advanced structural damage. But here's the thing. I've had 7 bone scans in my life. This is one of my bone scans that I had. A concurrent bone scan showing that my bone was normal metabolically. And as I told you yesterday, I went to a meeting in Estonia a couple years ago, an articular cartilage summit, and I decided to get a T1 row because that's the hottest thing in cartilage research these days, because it talks about proteoglycan content, and red is really bad. Well, I've got a really abnormal T1 row. Well, I'm still asymptomatic. And so what does the meaning of a T1 row? Well, I think it just means I have normal age-related chondromalacia patella, and it doesn't mean I'm pathologic. Okay? So, and here's the concurrent bone scan. At the time I had the T1 row, and that was 13 years out. And here I had a bone scan done for my wrist, which was positive. I showed you that yesterday. It gave me a chance to, this is my 7th bone scan of my knees, and this was just May, just a couple months ago. I'm still homeostatic. Again, I had a torn meniscus. That was the positive bone scan in 2009. 20 months later, my bone scan reverted to normality, total homeostasis. I remain in homeostasis. That's what's critical. Joint homeostasis is critical. That's what's associated with painlessness and the perception of it. Chondromalacia does not cause pain. There are no nerves there. What about malalignment? Well, that's the current thing that's very popular in my field. Well, if you look, there's a lot of articles out there. We've published some. Bill Post is really smart in West Virginia, others, that say patellofemoral pain does not correlate with malalignment. But it's a very popular concept out there because it's sort of seductive. Oh, yeah, the patella tracks badly, and that's what's causing pain. And things like McConnell taping. If you tape the patella better, the pain can go away instantaneously, and that proves it's malalignment. Are you familiar with McConnell taping, those of you who treat patellofemoral pain? It's Jenny McConnell's from Australia, and she developed this taping technique. You can sort of correct tracking, but I don't think it proves malalignment. I think it's unpinching synovium. It's kind of like if you're bitten your cheek and it's swollen up and you put your finger in your cheek and hold it away, you can get instant pain relief. I think it unpinges. I don't think it corrects malalignment, and it's only used temporarily anyways. I think it helps the knee to recover homeostasis from impinged synovium personally. Anyway, now, way back in the early 80s, we did a pretty extensive study on looking at malalignment characteristics. We had 104 patients with anterior knee pain, 79 controls. No statistical difference in any of these things. Q angle, incel-body index, Merchant view, Loren views, and things like meniscus of sclerosis that supposedly goes along with excessive lateral pressure facet syndrome. So none of this was statistically different. Now, Hans-Ole Stoibli from Switzerland also published some very nice work showing that the articular cartilage surfaces don't necessarily match the bony surfaces. And when we measure tilts and so forth, we're measuring the bony landmarks. But say this looks tilted maybe, but if you look where the articular cartilage surfaces are, it's mating perfectly. Okay, so maybe we're misinterpreting some of this tilting. So if you do a lateral release to try to make the x-ray look pretty, in fact, you may be creating a malalignment inadvertently. And so it's like here we start, we can make it the Rubik's Cube, we can make one aspect of this line up green, but in fact we're screwing it up at the metabolic level in a way, using that analogy. Now, so in my view, I wanted to start from scratch. This was like 30 years ago, and I said, where's the pain coming from? Well, it can't be coming from the cartilage. There's no nerves there. So where it's coming from? Well, it can come from some innervated structure. Well, everything but the cartilage is innervated. So any of these tissues is a potential source of pain. And I've come to view the anterior knee pain as a potential mosaic of pathophysiology with the different tissues that are innervated. And Biedert, and also from Switzerland, we have many Swiss, and we have them represented here today. Sanchez Alfonso from Spain have done a lot of work on free nerve endings in these areas. So I look at the patellofemoral pain as a potential mosaic of loss of tissue homeostasis of a variety of innervated structures. And each one can be different on different days. That's why patellofemoral pain can be variable. You can have pain over, laterally or medially one day, and it can be confusing. It's not just one thing. In my view, there are two main tiles of this mosaic in the local factors, and that is loss of osseous homeostasis and patellofemoral synovial impingement. Now, this is my kind of view of the pathology within the joint mechanical environment, direct trauma, intrinsic forces. Malalignment is kind of a load shifting, impingement, interosseous pressure, barometric pressure changes. Patients complain about it when the cold weather, but it's really often a barometric pressure change, presence of cytokines, altered pH, localized peripheral neuropathy, things like saphenous nerve impingement can cause it, and non-patellofemoral sources, referred pain from a hip, or even phantom limb pain. You can have knee pain with no knee at all in a above-the-knee amputation. Now, I was in Germany myself in 1982 at Landstuhl Army Regional Medical Center when I got my first bone scan of probably 10,000 bone scans in my life. And it looked to me, this is a 28-year-old female with patellofemoral pain, radiographs were normal. We didn't have MRI back then. But this kneecap looked like it lit up like a light bulb. We got a Glühbirne light bulb sign. So we started looking into this and seeing what was normal. We didn't know what normal was, so we had to do our own normality. So positive bone scan here and a negative bone scan here, and we looked into this. And when I got back to Letterman, after being in Germany, we did this comparative from controls and symptomatic people. And again, we found that there was no statistical difference in the indicators of malalignment, but there was a strong difference in controls. Only 4% of controls had a positive bone scan in the patella versus 54%. So this was statistically quite different, much more different than anything related to malalignment. So this is the point. From that point on, I became very skeptical of malalignment as a cause of anterior knee pain, and here was an indicator of loss of homeostasis. And so at this point, people said to us, well, the bone scan is like a nuclear SED rate. It's anything could cause it. It could be tumor infection, could be anything. We said, okay, that's fair enough. So we needed to do biopsies of this to prove what this was. And so that's what we did. And so a normal bone scan turns out to be osseous homeostasis. Here's the tide mark zone. Here's these nice spicules that look like pine wood striations. This is osseous homeostasis when you look at it. Now here's a biopsy of the same region. Here's vascular invasion across the tide mark zone, and here's this kind of burled walnut appearance. So it's quite easy to tell difference. It's like an early stress fracture, increased remodeling, if you will. And so when do we track these patients out? What happened to them with conservative treatment? So here's a positive bone scan, and we track this person out. When the symptoms went away, we bone scanned them, and the bone scan came back to normal. Now, we were very excited about this because this is the first time in the history of the world, I think, where we found a process documented here, loss of homeostasis of the patellar bone that resolved to normalcy when the symptoms resolved. This is like having a chest x-ray that's abnormal with pneumonia. When the pneumonia clears, the chest x-ray comes back to normal. Unlike a Q angle doesn't change. The trochlear anatomy doesn't change. None of these factors of malalignment changes between symptoms and non-symptoms. The chondromalacia can't change. There's nothing in a conservative treatment of chondromalacia that can possibly change chondromalacia. So how does that possibly make any sense? It doesn't make sense at all, and I submit to you. But this changed. Here was a process that was present that changed. So we were excited about loss of homeostasis, homeostasis. This was the original insight, Einsicht, to something going on, to a heretofore enigma. Now, as I showed yesterday, Stanford Radiology has now used PET-CT to show in higher resolution the stuff we found 30 years ago. It kind of pissed me off because they didn't reference my work, but they referenced an article that referenced our work 6 times, so I'm going to write them a strong letter one of these days. But anyway, that's an aside. Now, what about the... So here's the bone. How can the bone be part of the problem? Well, here's the vessels in bone. Now, if you stain these vessels for nerves, this is something that was an eye-opener for me. Look at the network of nerves that are going along with the vessel, called neurovascular. This really shows that idea. Until I saw this picture, I never realized how much nerves and vessels go together like this. It's really impressive. Now, we were very interested in the intraosseous source of pain as a possible tile of this mosaic. Now, this is my very first bone scan, by the way. I showed you my 7th. This is my first. This was done as a control, as I was part of the control group back in 1983 at Letterman. And so I'm perfectly normal here. And so I was interested in the intraosseous environment. So to do this, we needed control data. So I said, I'll be the first one there. So I had one of my residents put a 15-gauge jam-sheety needle into the medial facet of my right patella under local anesthetic. And I didn't feel any pain, but I felt a trabeculae crack as he pushed this 15-gauge needle into my patella. And so we hooked up an arterial line to get pulsatile pressure measurements. And as he flushed the line, that hurt like crazy. That was lancinating pain. So I can tell you, the intraosseous environment is very sensitive to increasing pressures. And so that hurt. And then for 7 months after that, I really hurt. So it was clearly a known injury to the knee. So I couldn't ask anybody else to do that. So that part of the study came to a screeching halt. But then if you have lemons, you make lemonade. So here's the homeostasis, prenatal penetration. 7 weeks post, you can see an increased uptake right where the needle penetration was. And then 14 months later, I'm back to homeostasis again. So this is the first human model I'm aware of where we established homeostasis, a known amount of trauma, loss of homeostasis following the needle penetration, and restoration of homeostasis again. So again, I'm intimately involved in my own theories. And this is what I think happens to direct trauma. Now, we came up with a theory of bone homeostasis, and here it is. Okay? It's like Parcheesi. You start with homeostasis. You have variable triggers, supraphysiologic loading, pathokinematics, excessive cytokine production, and you start this increased remodeling activity. If you have equal bone turnover, you can come back to homeostasis with no change of morphology. You can have net bone formation. This will be an active osteophyte formation or osteosclerosis, and you can come back to homeostasis. I've seen big osteophytes that are dormant with bone scan normality, or you can have net bone resorption with RSD or osteolysis, and you can still come to homeostasis, and that'll be osteopenia that's dormant. And so this, I think, explains model of bone homeostasis. I think it covers all the bases. And you can have a knee that has all 3 of these things going on at once in different regions. But homeostasis is the goal still. Of course, what we really want is here, which is no net bone change. That's what's happened in me, fortunately. Now, what's the principle of treatment under these conditions? Restoration of function. That's our goal in orthopedics. Well, what's the function of the knee? Well, the knee functions as a kind of biologic transmission. And again, once again, the Europeans have the greatest insight. This is Menschik. He is the most brilliant guy in the knee I know, along with Werner Müller. He came up with this concept of the Burmester curve to have a mathematical rationale for the asymmetry of the collateral ligaments. But it was his insight that the knee functions as a kind of biologic transmission. Its purpose is to accept and direct forces between the femur and the tibia under a variety of loading conditions. That's what a transmission basically does. And the muscles are the molecular engines. And It's a 1 trillion cell, living, metabolically active, self-maintaining, self-repairing system. In this analogy, the muscles are the molecular engines that provide motive force across the transmission, millions of motor units or millions of cylinders under the control of the cerebellar proprioceptive axis. It's quite complicated. In fact, I will take an intact cerebellum over an intact ACL any day of the week. This is much, much more important to knee function than any particular ligament structure, if you think about it. Anyway, the purpose, again, is to accept, transfer, and dissipate loads. In this idea, the ligaments are sensate linkages, the menisci are sensate mobile bearings, muscles as engines. Now, the patellofemoral joint is a special component within this transmission. It functions as a large slide bearing within this transmission, but the forces here are the highest of any human skeleton, any component of the human skeleton. It often exceeds the load acceptance capacity of this biologic structures, leading to microfailure and painful loss of tissue homeostasis. Now, I mentioned this concept yesterday, the envelope of function. Now, had anybody heard of this concept yesterday, the envelope of function? Anybody read about this yesterday? You'd heard of it before? Well, this is an idea that's within at least the sports medicine community, and it defines the capacity of the knee to accept and redirect forces. It's a load frequency distribution that defines this capacity. This might be a maximal envelope for a human. It looks kind of complicated. It's quite simple. Let's go over it briefly. So again, maximal envelope of load acceptance. So point here would be a low frequency, so a one-time high load event, like jumping from a 2-meter height. If you're 20 years old and everything's intact, you can probably get away with it one time. But nobody can jump from a 3-meter height without breaking something. This is a load out of the envelope. This is kind of like a flight envelope for an aircraft, if you will. Down here is less load, but more of it, like 2 hours of basketball. A lot of start-stop activity. I call basketball a knee killer because it's easy to cross this threshold into failure. Down here is less load, but more of it, like walking 10 kilometers at a slow pace on the flat surface. Sitting in a chair doing nothing, swimming 10 minutes, bicycling 10 minutes. Activities of daily living would be in the middle. Now, we call this the zone of homeostasis, or loading anywhere in here would be not only compatible, but inductive of tissue homeostasis of the normal knee. Now, if we take anybody in this room, a normal person, and force them in this part of the envelope by putting you at bed rest for a month, you're going to lose homeostasis from too little load. Calcium loss from bone, muscle atrophy, and that sort of thing. This is the problem that people on the space station have. They just don't have enough trigger to keep homeostasis going within the musculoskeletal components. They always come back with muscle atrophy. But it doesn't take much trigger to keep you into the homeostasis zone. This is why couch potatoes don't get arthritis much, because that's enough a trigger to keep them in homeostasis. Most people lose homeostasis from too much load, run 5 miles a day, start 10 miles a day in preparation for a marathon. A stress fracture is a classic example into the overuse zone. And then if you put too much force across the knee, or too much energy, and load and frequency is equivalent to energy, you'll get into the zone of structural failure, where you actually break something. Now, Steve Arnowski, who is our best basic science guy, I'm a theorist. In fact, Runner's World called me a renegade knee theorist, which I love. I think that's my role in my field. I'm a theorist. I theorize this, but I'm not a scientist. But Steve Arnowski has proven this to be so scientifically. And it turns out that all joints respond to differential loading in one of 4 zones: disuse, homeostasis, overuse, structural failure. The outer limit of the homeostasis zone is what we call the envelope of function, or the envelope of load acceptance. So my goal is to expand that as best we can. So you can start off with a person who has a normal envelope, and they get a dashboard injury or climb too much, and then that envelope diminishes. And here's the real problem with patients with anterior knee pain, is that when it diminishes so low that that activities of daily living are out of that envelope, this is where you get a real problem, because their normal activities of daily living then subvert that process. So the treatment for me in these patients is to decrease loading to within the current envelope of function. In other words, just stop doing stuff that hurts, which is just a common sense thing. That's what 400 million years of vertebral evolution wants you to do. Pain is like a red light on a dashboard saying transmission overload. That's how I explain it to my patients. An anti-inflammatory program and rehabilitation. So now if you just have a little bit of injury and you can recover and it doesn't drop below activities of daily living, then we hit our knees against desks all the time and stuff like this, mild injuries, and it recovers without anything special. But if you have enough of an injury and the load acceptance capacity drops below activities of daily living, and we're doing normal things like going to work or store or movies and restaurants, that sort of thing, and our load acceptance capacity is below that, then we could recurrently trigger and recurrently subvert this underlying capacity of healing. And this is the essence of why patellofemoral pain often is a persistent problem. And so you've got to get in within that envelope and figure out whether factors play a role here. And there can be proximal and distal factors. Jacques will tell you that the things like hallux rigidus can be a factor, and you must look for these other factors and correct them. But primarily, you've got to get in that envelope and let Mother Nature do the job. The other factor here to understand is healing is a rate-limited process. You can't force it. The analogy I always use for this is like the maturation of a bottle of red wine, say a Chateau Lafite Rothschild. It takes 8 to 10 years to make that grape juice drinkable. And the vintners understand the chemistry to a degree, but they don't control the chemistry. They cannot make a drinkable wine in a week or a month or a year. It takes 8 to 10 years. And the same process here. That's chemistry. This is biochemistry. So it's very important that you make sure the patients understand this. Now, I'm a big believer in an anti-inflammatory program. So NSAIDs, I have a very low threshold for steroid injection. Kenalog is a name of a steroid, a particular brand that I like to use. I'm also a fan of tissue cooling. Now look at this. This is a bone scan of an ankle sprain. In other words, it was thought to be a ligament problem, but it also has a bone and osseous homeostasis component. And this is a patient we brought back a week later and iced for 20 minutes. And look how diminished we can get that loss of homeostasis just 20 minutes of icing. So cooling does make a difference. I'm a big fan of cooling for 20 minutes 2 or 3 times a day. And rehabilitation. I'm a fan of rehabilitation, but it must be painless. It must be within the envelope of that particular knee. And if you're doing rehabilitation with things like lunges and extension against resistance that hurt the patient, that cause pain within that knee, you're subverting that healing and, in fact, making the patient worse. So it must be within the envelope. We have this phrase in America, no pain, no gain. That only applies to mild muscle aching after workout. Pain in the knee of any type is a problem. Look at this gentleman here. They're getting him on the Cybex thing or whatever, and look at his pain. This is no good. Or lunges, no good. Stretching, yes. McConnell taping. This is the McConnell taping technique. If it helps, if that makes the patient worse, that's no good either. It must cause the joint to be feeling better. Now, the patellofemoral joint, because of its high forces, is unforgiving of aggressive or ill-considered surgical intervention. An ACL reconstruction is much more forgiving of placement on the femur than the patellofemoral joint is. And again, as I said, iatrogenic injury is the most common. To me, the knee is a very important system and a high-value asset, and it should not be risks. Again, these are the iatrogenic cases you want to avoid. There's a Fulkerson osteotomy and Elmsley osteotomy, chondroplasties, ACI, which is not a magic wand, and then even patellofemoral replacements. And this is not a magic cure either. Here's a patient who had such a thing, but now look, it's displaced in osteolysis, and she's worse off than she was in the beginning. So this is a very dangerous area to operate on, in my opinion. And also the concept of patellar instability. Very often, the symptoms of patellar instability are due to a reflex inhibition of the quadriceps secondary to synovial impingement, misinterpreted as maltracking. And so one has to be very careful about not making that concept. Now, the rationale for a peripatellar synovectomy is what I do. If I'm going to do an operation for failed conservative treatment for anterior knee pain, almost always I'm doing it because of peripatellar synovial impingement and recurrent effusions. This is the problem. So my rationale is that's where the nerves are, and it looks something like this. And so this is the kind of thing I'm looking for, and I almost always find this stuff. Normal synovial cells, understand this, are just a cell or two thick, but when it gets impinged, they go from 2 cells to 1,000 cells. You pinch them again, they can go from 1,000 cells to 10,000 cells. You pinch them again, they can go to 100,000 cells. And so these things, these tissue zones swell up physically, and then it's like a swollen cheek tissue. They get to the point where the patient cannot control it. And that's the rationale for going in and gently trimming out this region of pathologic synovitis. And here's a good example of what I'm talking about. Gently get rid of this stuff. I'm not aggressive. I use gentle, low-energy, conservative treatment. I stop when I see normal fat cells. I'm not aggressive. This anterior interval resection, I'm against aggressive resection. Conservative. But this is the kind of stuff we see under a microscope. This is the pathology. Normal synovium, synovitis. The pathology is synovial hyperplasia, lymphocyte aggregations, chronic nonspecific proliferative synovitis. That's where the nerves are. And now, if you do a synovectomy, you must avoid a hemarthrosis. Meticulous intraoperative hemostasis. I use 40 cc's of 1% lidocaine with epi subsynovially, and I put 50 cc's of 0.25% marcaine with 10 milligrams of morphine intra-articularly too. And I always put a drain in for at least 3 hours because you might miss one of these vessels, and if you do, it's better to have a drain in overnight. And very gentle post-operative rehabilitation. Okay, now I want to share with you, I have 10 minutes more of my time, and 10 minutes because I didn't get started right away, but I want to share with you a specific case report that puts everything together. And this is what I call the Carrie Burnett story. This is a real patient that came to me sort of out of the blue, and I want to share her experience with you, and she's allowed me to do this. Now, this is Carrie Burnett. She is a very nice kindergarten teacher who is an example of the failure of the current structural and biomechanical paradigm. This is a true story. I received an email in December of 2012 from this 32-year-old kindergarten teacher. She said she had a 3-year history of increasing patellofemoral pain. She never had any symptoms at all until she had a couple of days sitting with her kindergarten kids on the floor with their knees hyperflexed. She called it crisscross applesauce. She developed bilateral patellar pain, left worse than right. So our family MD, who sent her to an orthopedic surgeon at the local hot shot medical center here in Rochester, New York. The orthopedic surgeon diagnosed patellofemoral pain syndrome due to malalignment, the current, thought, without really thinking much, and referred her to physical therapy for rehab, including core exercises, stretching, but emphasizing quad strengthening to correct maltracking patella. Okay, here's the exact physical therapy place where she went. They had her start doing immediately lunges, immediately partial squats to correct malalignment to get her quad strong. Well, of course, this immediately did what? Caused her symptoms to increase. Immediately. It made her worse. Crazy. Her symptoms increased immediately. But here's the thing. She was told to continue her symptoms despite increasing pain. She said, you must work through your pain threshold. Must work through your pain threshold. This is the kind of aphorisms that the physical therapists are brainwashed into. I call them PT Nazis because they're doing stuff she was sent there for these symptoms, and they're doing stuff that actually make her symptoms worse. What's the logic? What's the rationale for this? It's ridiculous. So her patella pain became so severe she could not come in, and they called her up. Well, the sharp pain you're experiencing is normal. You should expect it. You must come and move forward. Be productive. This kind of stupidity. And so anyway, she went back to her orthopedist after all this torture. Says, well, you must have a lateral retinacular release to correct your malalignment. Well, lateral retinacular release doesn't correct malalignment, in fact. Well, the only time she felt better in all this time was the 3 weeks right after her lateral retinacular release, where she wasn't in physical therapy. Her knee was in her envelope. Her knee got some chance to heal a little bit, but then they put her right back into PT, and all the same pain returned. Now, this is not her, obviously. It's just a picture of another person getting a lateral retinacular release. She endured months more of this painful therapy. Then she went back to the same orthopedist who told her the reason she was still having pain was that he hadn't corrected her enough. Hadn't corrected her enough. Oh, my God. And then told her that what she really needed to make things right was a procedure called an Elmsley tryout. This is a picture of it. Now, this is what's interesting. I'm in the process of publishing this. I think I'm going to send it to Ed Voitis' journal because I want the physical therapist and the orthopedist to read this. This is a direct quote from his notes. I got his chart notes, Christian. This is a direct quote from his notes. It says, we will do an Elmsley tryout and also an advancement of the VMO, 2 huge surgeries on this poor little knee. I told her it would take a good 6-month recovery, probably take 18 months or more, not 6 months. I did tell her that this is a very hard problem to treat. That's true. Therefore, as a consequence, it may or may not help her. That's also true, probably not help her. I did tell her alternatively to this, if she proceeds with this and it is still painful, we could just proceed with a patellofemoral replacement. Just tosses this off. Oh, if this doesn't work, we'll just put a patellofemoral replacement. She's only 32. A patellofemoral replacement? She just started off with mild intermittent pain. This is just a travesty of this guy not knowing anything about the knee. Just proceeding blindly with this malalignment concept. This is just sickening for me to read. And I said, this is my response. Are you kidding me? It's unbelievable. Well, she got a second opinion in Buffalo, and he said, well, do you want less pain or you want more function? You know, just got like this, again, just along with the same paradigm, you know. Just, to me, this is also stupid. It reflects no real biological understanding of the patellofemoral joint. So finally, she began an earnest internet search. She basically happened upon some of my work and then on the pathophysiology, and she basically contacted me. She eventually came to San Francisco, where her history was consistent with sudden onset of pain from hyperflexion, mild diffusion, and nothing that goes along with malalignment. This doesn't make sense. This is not a malalignment history. You know, her symptoms have made her worse: stairs, squatting, lunges, hamstring stretches, quad sets, et cetera, et cetera. Resting made her better, mild cooling, pool treatment, gentle quad exercises, Advil liquid gels. Physical exam, no evidence of malalignment or maltracking, normal Q angle, thin build, peripatellar effusions and tenderness, you know, synovial impingement, straight leg raising was painful. Here's her imaging, okay? She got some synovial impingement, no malalignment, bone scan slightly positive. Everything's consistent with, you know, loss of homeostasis.
Can you show us that impingement?
Yes. Here. And the fact that she's got an effusion goes along with that impingement as well.
It looks like it's bad laterally on the left axial view too.
Yeah. Yeah, I think so. I think that's true. I think it's peripatellar. It's not gross there, but she's got an effusion that, I mean, you have effusion and this bit of swollen stuff, and physically altogether, there's no doubt in my mind she has peripatellar impingement and effusion. It's mild, but it's real. So here's my assessment. Misdiagnosis of malalignment. Every treatment directed towards malalignment made her worse. Actual diagnosis: loss of patellofemoral tissue homeostasis, recurrent synovial impingement, mild loss of patellar osseous homeostasis due to transient overload event, and then perpetuated by supraphysiologic loading that subverted her knee's healing capacity. And again, all the stuff we talked about. So 7 mistakes in my opinion. Number 1, misdiagnosis of malalignment. Mistake number 2, referral to physical therapy, emphasizing quad strengthening. Mistake number 3, PT's insistence that she continue even though it hurt, violating the first principle of medicine, primum non nocere. Mistake number 4, orthopedics misinterpreting the patient's non-improvement as a cause to proceed with a malalignment-oriented procedure to correct maltracking. This was never a maltracking problem, in my opinion. Mistake number 5, orthopedics placing the patient right back into physical therapy, which caused her symptoms to increase. Physical therapist insisting she continue to perform painful exercises even if it hurt her. And the final mistake is to then suggest he hadn't corrected her enough. Every step here is a mistake. The successful treatment approach is to instruct the patient in a simple but biologically sound and effective concept of the envelope of function. She had been loading out of her knee's envelope for years, and what we need to do is to get her in a pain-free envelope and an intra-articular 40 milligrams of Kenalog, which is a soluble and also solubilized ibuprofen. She has improved 85%. In fact, I got an email from her just this morning saying she is doing really well, and she can actually play soccer with her cousins, which she wasn't able to do. So she's done fine. With just the only intervention I did was put some Kenalog in her knee and instruct her in the envelope of function concept, which she has done very nicely. So what's doing the work here? 400 million years of vertebrate evolution. It's built in. It's designed to do it, and we just need to unmask it. And I have 5 more minutes, so I just want to show you one other concept here that Steve Arnowski has developed, which I think is really important. This is Arnowski showing the concept of intracellular homeostasis of living tenocytes. And he's showing, these are living tenocytes here, and he's able to light up the intra-articular homeostasis characteristics with a certain process. And he shows that at 0 degrees strain, there's no activity. At 2% strain, there's some activity. At 4% strain, it's at its maximum. And at 6% strain, this is now diminishing. And so, what the key principle here of tissue homeostasis, the actual engine, the real underlying process of tissue homeostasis is through biological transduction of load. And so you have moderate loading, a differential cell matrix deformation, biologic transduction gives you tissue homeostasis. And if you have low, moderate, high, or very high loading, you get differential responses. So if you have low loading or 0 degree loading, differential cell matrix deformation is minimal, and you have loss of tissue homeostasis due to disuse. Okay? If you have moderate loading, The moderate differential cell matrix deformation is moderate, and you get tissue homeostasis, anywhere in the 1 to 4% strain. This gives you tissue homeostasis. This is what most of us have throughout our lives. This is what we want. If you have high loading, it's high cell matrix deformation, and you get loss of tissue homeostasis due to overuse. This is the 6% strain region. And if you have very high loading, you get beyond 6% strain. That's structural failure. So he has explained the engine, the actual mechanism of tissue homeostasis in his laboratory. Low, moderate, through biologic transduction. The knee is biologically and metabolically resilient within a certain range of loading. And I offer you the concept of that every joint or musculoskeletal system has its own envelope of function, or envelope of load acceptance is the term I use for patients, and that oftentimes the simple action of diminishing the loading to within that joints or system's current envelope of function allows 400 million years of vertebrate evolution, which is doing the heavy lifting anyway, to help restore that. And sometimes we surgeons have to go in and get the pebble out of the shoe, or restore the ligament, or find the hallux limitus that's stiff and release the tendon, or other things that may be a factor here. But I'm arguing that less is more almost always, and approach this gently rather than slash and burn like many of my fellow surgeons do. And I think that's enough. Thank you.
Any questions?
I know you very well, and I heard your lectures in some other meetings much bigger than this one, and that's your style, and I appreciate your lecture. But I think that one of the problem of the well-developing country is too much money, too much surgeons, and less patients. And then if you want to do something and earn the money in operating room, you have to do some operation, which is not good for the patient, but it is a harm for the patient. And another problem is you can do the faculty, medicine faculty in America, but you will still not be very good educated. So you have some percent of the doctor who are not think very clever, and maybe they are not educated, and they don't they miss the diagnosis because, as you say, we don't know what's the problem, where is the pain in anterior knee pain, what is this you do many hypotheses, but we still don't know what generating the pain. So this is the reason why we have so many names for these symptoms. And so this is the reason why the Mayo Clinic puts this sheet on the internet. So what I do in such a patient, if I have clearly instability of patellofemoral instability, and if I can diagnose the reason of instability, then I operate it. If I have just anterior knee pain, then I think about synovial, this and this and this. Maybe I do in just 5% diagnostic arthroscopy. If I find some hypertrophic synovia, I do very gentle resection like you, that not to do a lot of blood in the knee, and then you have then bad hemostasis, everything you do harm. Or in most of cases, I don't do nothing. But the problem is the patient came to me and asked me, what is the reason of my pain? And I don't know what is. Then I have to put some diagnosis, and I have to explain something why, and why I don't want to operate it.
Well, I think your observations are apt, and I think you're correct. There are many surgeons, not just in America, I think in Europe too, that are looking to operate on something. They get paid for what they do, and they can justify it because, oh, here's chondromalacia on an MRI, and the Mayo Clinic said that's the problem, and they're protected. They can't be taken to court, so they're not moral, but they're protected. And I think it happens 100 times a day, every day. I think you're correct. And you know about the fact of putting a name on this. We don't have a code for what I'm talking about in the American insurance lists of diagnoses. I have to code out my anterior knee patients that I think are due to synovial impingement or interosseous pressure from the patella. I have to, or positive bone scan in the patella. I have to code these out as Chondromalacia patella 717.7. That's the closest diagnostic code, but it's not the right code. And so I'm hamstrung myself due to the lack of sophistication of the coding system and the lack of agreement on what the source is. But I sit down and talk to my patients. I give them a copy of my articles that goes into some depth. A lot of my patients are college graduates, and I try to explain this stuff. But here's where the envelope helps, because the envelope summarizes all the various factors that might be there. And it doesn't make any difference what the factors are if you drop the load enough, and it's not something like complex regional pain syndrome that won't respond to it. But most of these other factors will respond if you get the knee, if you drop the load across the knee low enough, and you have normal healing properties, and you're within a standard deviation of the mean of normal patellofemoral pain syndrome cases. That doesn't make much difference what the source is. That knee's genetic components of healing can restore healing, but it takes a long time. The real problem here is having the patients be patient long enough. It can take 18 months, and most patients aren't patient, and they want to go right back to sport, and so the day they feel better, they're out playing volleyball or something, and then they subvert their healing. That's the real problem. So I like looking at it in broad strokes, and there's certain tiles of the mosaic we can get at, like the synovial impingement tile, and I like to go with that. But what I hate is this business of, oh, you're malalignment, you go to a physical therapist, the physical therapist whips them with a whip and makes them worse. And that is an incorrect way to go, and I'm fighting against that. Anything that makes them worse doesn't make any sense to me, and that must stop, in my opinion. And I'm open to other ideas. You know, let's say acupuncture or spin around 3 times, bow to the east, you know, hang upside down like a bat. I'm not sure what's going to work, but if it's anything short of heroin that makes them feel better, you know, that gets them in their envelope or broadens it, I'm open to. And I'm sure there'll be new concepts in the next 10 or 20 years that helps restore that. But the bottom line 20 years from now, 200 years from now, 2,000 years from now is joint homeostasis is where it's at, 2,000 years from now, 200 million years from now. That's where it's at. How we get there, I don't know exactly. But I know safety is important, and that's my calling card.
Yes, and thank you, Dr. Dye. That was a very interesting presentation. And I agree with you with regards to the envelope of function, and I normally explain that to my patients as well. There's 2 things really I wanted to sort of ask you and pick your brains about. One is, when you have patients who've got maybe some instability issues, let's say trochlear dysplasia, increased TTTG offset, external tibial torsion, but they've not been symptomatic for all their life, but maybe an injury or something like that pushes them out of that envelope of function, and then it's very difficult to get that patient back into that envelope of function, if you like, or comfort, if you like. And having followed your sort of conservative approach in management, you get them through maybe 6 months, 12 months of that. They seem better because they've reduced their activity levels, but as soon as they get back to doing anything more what they enjoy or like doing, they're back symptomatic. Would you advocate in that patients, if they have got any underlying pathology at that stage, to actually correct that then, to make any difference?
Yeah, that's a really great question. And my instincts, I'm a surgical minimalist, happily so. But there are people that I would trust to evaluate and perhaps surgically correct that problem. David DeJour, perhaps, somebody like that. I would maybe put in the hands of that person who has a lot of experience with it, but that is a tricky part of the joint to operate on successfully and reliably. And I like predictability and safety. And the operations to correct that are, especially with trochlear dysplasia, if you're going to do a trochlearoplasty, that operation makes me nervous as hell. Personally, even David DeJour's hands, because if you do a trochlearoplasty, you're deep in it. What about the patella that's already adapted to this, and you make it go into a trochlea like this? All of that stuff just makes my skin crawl. But the concept is an interesting one, and yes, I would consider it, but I would have to be forced with a bulldozer myself.
Excellent, thanks for that. And the second caveat or second point to that question really is, let's say if you see a patient who've got definite established instability with pain, right? Let's say the patella is definitely tracking, they've got increased EG. What about that patient group, which you know that no matter what sort of conservative measures you're going to go, it's not probably going to help?
Yeah. No, I'll take that patient on. But in my experience, people talk about this instability. It's like, oh, that's legions everywhere. In my own practice, and I see per primum cases all the time, that is a rare patient for me to see that wasn't operated on by somebody else. That sounds like an iatrogenic problem to me. But in my own practice, that is a rare patient. But yes, I would take that patient on and I would correct that as gently as I could. Yes, I would.
Excellent. Sorry, just one other question. I don't want to be sort of taking over the floor here, but with regards to your measurements, when you see the patients, do you actually do a patellofemoral dysplasia profile measurements on MRI scans or CT scans routinely, or would you preferentially go to a conservative approach first and
Yes.
then maybe do?
I don't make any measurements. I don't look at the Q angle. I don't look at any of that stuff because I don't think it matters in my assessment. If there's instability, that's another story. If they're dislocating, if they're having subluxation events that I think are real, genuine instability, not just giving way from a synovial impingement, which I think a lot of instability in fact is, then yes, I'll do it. But most of my patients are anterior knee pain that are oftentimes due to, well, I hiked too much, or I sat too much, or something, or hit, or, something triggered it. No, I don't routinely make measurements because I don't think it's, what am I going to do about it? I'm not going to change the Q angle. I'm not going to do anything about it because I'm going to approach them conservatively anyway. So I don't usually make those measurements.
Okay, thank you.